right, so good morning. My name is Leon Dewar. I'm a pediatric neurologist, and what I'm going to offer today is a bit of an idea and application of how much of Tourette syndrome could perhaps be an executive function disorder. And this is a bit of a personal opinion more than anything else, but I think it's important that we try to conceptualize Tourette syndrome and think about it in a way that's going to end up being most helpful for people who have it. So to just give a little bit of a backup or an overview, Tourette syndrome is defined, as it was named by Tourette, and it's defined by the presence of motor and one or more vocal tics for over a year with a childhood onset and no other medical or neurologic problem. This has been a little bit of an evolution. The old classification scheme talked about children could have a certain period of time where they were tic-free or not. They also specified a distress or impairment, but those have pretty much gone away with the new classification. So Tourette syndrome is defined as a tic disorder. Now, this is a video of a young lady who's having some repetitive behaviors, which would be tics. These are rapid, jerk-like movements. Those would be motor tics. If there's any sound, we characterize those as vocal or phonic tics. And tics are interesting because they're irresistible but suppressible. Some people have tried to come up with terms for this, whether this is an involuntary movement or an involuntary movement. When you talk to folks who are experiencing tics, they'll often describe a need to perform them, which sounds a little bit like compulsions. Premonitory urges are often described, which usually has a sensory component. A person will say, well, my eyes itch, I have to blink, and I get some relief of that itch. But it's not always recognized. But that's what tics look like. They tend to start in young children. They occur more often in boys. Motor tics usually start before any vocal tics and are more common than vocal tics. The head and the face is the distribution that one sees before the body's involved, and simple tics, which are more simple movements, usually appear before anything that is more of a complex behavior. And there can be a peak in severity where these tics will taper off quite a bit with age. And these are just sort of general features of tics. Most individuals experience multiple types of tics, and they wax and wane in frequency. And there's a tendency to correlate with stressors or the state that the person is in. There are certain times of the day when people may not experience tics at all, while at other times they may be quite prominent. Tics themselves are common. 10 to 20% of school-aged children can have tics at one time or another. These people do not all get a diagnosis of Tourette syndrome. And they're typically seen by pediatricians, and the basic teaching for general practitioners is to sort of say, well, it's likely to go away. But it's not really clear how often that actually happens. When there are persistent tics, children will typically be referred to a psychiatrist or a neurologist, and that really depends on the availability. If you have a lot of child psychiatrists in your community, that may be where you end up. But tics can make up to 20% of an academic child neurology practice. So again, this points out how common this actually is. But it doesn't really answer the question. I mean, what is a tic? Why do we have them? Well, we certainly have a number of automatic stereotyped behaviors. And these are distinct from just a reflex. I mean, if you step on a nail, you withdraw your foot. That's a pretty simple thing. That's a reflex. But more complex behaviors that we do really without thinking about it include things like walking and walking over terrain. You don't have to think about that very much to take a step to stay out of the way of impediments. Chewing, grooming activities. In other animals, we talk about territorial maintenance. These are all automatic behaviors that we engage in that we don't really have to think about very much. But they are regulated not at a reflexive level. These are regulated at a higher level, which includes the cortex and the basal ganglia, which is within the brain. The other interesting feature about this is that there's always been an implication that dopamine was somehow involved in this, that dopaminergic systems modulated or moderated the expression of these automatic behaviors and tics. And that kind of leads me then back to an issue that I've had for a long time with respect to this whole definition of Tourette syndrome. It's kind of mandated that you have to have motor and vocal tics. Even though in families where you may have an index case with clear-cut Tourette syndrome, you'll often see other family members who only have motor tics or only have vocal tics. Do they have something different? Probably not. They probably have the same thing, but we're a little bit limited in terms of how we name this because Tourette syndrome is a tic disorder and they have to have both motor and vocal tics. The other issue relates to whether tics are actually abnormal or a problem for somebody. Do they truly cause distress and impairment? That's actually a small minority of individuals that experience true distress or impairment as a consequence of their tics. And it's not exactly clear why those people do. Because it's certainly not a matter of the number of tics or the frequency of tics that cause that distress. But I think as Dr. Marullo mentioned, and something that's really kind of clouded the picture here has been the identification of comorbidities with Tourette syndrome. As many as 75 to 85% of individuals that have a diagnosis of Tourette syndrome will also manifest obsessive compulsive disorder, attention deficit disorder, a learning disability, or some other type of psychopathology or behavioral pathology. It's also hard because when you're looking at an index person and they may be manifesting a complex tic, they may describe it in a way that certainly sounds a lot like a compulsion. So it's really hard to identify what's what. And so I think that, and as Dr. Marullo kind of mentioned, that when we think about executive dysfunction or executive function, it seems to be so much more obvious in those who have these comorbidities. And this has kind of led me to be thinking about this as Tourette syndrome is way more than just a tic disorder. And it's really important to kind of get a sense in an individual, what's the hierarchy of the signs and symptoms of the disease? What's the big problem? What's the source of distress or impairment? Because it certainly may not be the tics, even though that is what defines the syndrome. There's a real need for competence among caregivers, and I don't mean just the physicians that you go see. This involves teachers, parents, psychologists, etc. And this has also had a big impact on how we think about Tourette syndrome and how we study it, because it's very difficult to get a population of patients that all have sort of the same degree of comorbidities. Just as a kind of an example of this, and this is taken from the genetics consortium that the Tourette Syndrome Association has funded for years. This is just from a large population of patients and looking at their general characteristics. And so if you take a large group of patients who have Tourette syndrome, you actually find that only about a quarter of them have tics alone. It's a fairly small number. Whereas if you broaden that and think about Tourette syndrome plus obsessive compulsive disorder, that's almost a third. And what I could term the whole Megillah, Tourette syndrome, obsessive compulsive disorder, and ADHD, that's another third. And they're a pretty small percentage, only 10%, who have tics and attention deficit disorder without OCD. So you get a sense of how complex these presentations can be. And so it's been put forward that Tourette syndrome is really more of a model of a neuropsychiatric disorder. Now, I don't have that much influence. We're not going to be able to rename this condition something else. And I think people have tried to come up with other criteria for the disorder and failed. But we have to think about how do we conceptualize this condition. It's childhood onset. There's a variable course of tics. And again, a frequent association with comorbidities. It's reported anywhere from 30 to 60% will have this OCD, 50 to 90% attention deficit. Again, it shows us how important it is to understand these comorbidities and try to then address them. To make it even a little bit more complicated, and I think this is from an old NIH publication, looking at neurodevelopmental disorders in general, one sees this degree of overlap. So off to the right, you see Tourette syndrome, ADHD, and OCD, and how they all sort of mix together. But then if you add in autistic spectrum disorder, there's an overlap both with Tourette syndrome and OCD, as well as schizophrenia. And then if you just take the, this is not politically correct, but MR, mentally retarded population or developmental delay population, there's a big overlap with the autistic spectrum kids and the schizophrenics. So it becomes really complicated then when we're trying to conceptualize this condition. So it brings me back, and I'm going to ask this question a couple times. What is Tourette syndrome? This is the old story of the blind man assessing the elephant and trying to identify what this object actually is. One way to think about this, or one way to understand Tourette syndrome, is kind of the standard way that physicians and researchers do. And that's by looking at pathology. So for something like Alzheimer's disease or Parkinson's disease, things like that, they look at gross pathology to identify where the problem is. In Tourette syndrome, there is a brain bank. There is a way to donate a brain from a person who has died who actually who had Tourette syndrome, but there's still not a lot of clinical material out there. Those studies that have been done have not been that informative. Gross anatomy is normal, and the reports themselves are somewhat limited. And so the way that it's approached now to try to understand this disorder from a biological perspective is to do studies in vivo studies, basically live humans. Now, conventional imaging studies with MRI, CAT scan, this is all normal. There have been attempts to look at the volume of areas within brain, but they've been very inconclusive. But more sophisticated imaging techniques have at least given us some clues as to where there might be a change or a problem. This is an example of a study done at Yale a number of years ago looking at something called functional MRI, which looks at brain activity. Now, the picture on the left is really just sort of to show you the anatomy. The picture on the right shows an adult who is suppressing their tics while they're getting an MRI. And the colors mean that if it's a blue area, then the activity is decreased. If it's red or yellow, the activity is increased. And so one gets a sense that there are changes within brain when people try to suppress their tics. Well, that's maybe not all that interesting, except the location is. Because that one sort of in the middle, that red area in the middle, is the anterior cingulate cortex. And that is part of that frontal system that Dr. Marullo was talking about, again, implicating the executive regions that are involved in executive function that may be involved in tic expression. Similarly, using something called PET, positron emission tomography, looking at blood flow and brain activity in people who have tics, we see lots of areas that light up, and take me at my word here, all these areas are associated with both the frontal system as well as executive function. And finally, and I think probably this is the most recent information that again I find interesting, comes from Brad Schlager at WashU. And you can use functional MRI not to look at just blobs of brain. What you can do is that you can look at the connections between regions of brain. And by using functional MRI, what you do is you have somebody in the MRI machine and they carry out a task. It's reading and speaking aloud. There are various types of tasks depending on what you're studying. But using a lot of math, what they have been able to do is show that there are specific regions of brain that really do like to talk to one another, and have very strong connections. Now, these connections get stronger with maturation. And so there is a pattern of connectivity which is typical for an adult and one that is common for a less mature brain, which shows a more diffuse pattern of connections. They're not quite so strong. It's not quite as directed. And that's normal. What's interesting is that in Tourette syndrome, the connectivity is much more distributed. It shows a less mature pattern. And if we go back to what Dr. Marullo was saying about the connections of the frontal system with the rest of the brain, I think that conceptually this makes some sense, that there is a problem here that can be explained by connectivity which impacts our understanding of executive function. Now, I mentioned that dopamine was associated with tics. Well, there are other amine compounds that have been implicated in Tourette syndrome. Serotonin, or 5-hydroxytryptophan, is the one that we think about as being associated with obsessive-compulsive disorder, norepinephrine with attention deficit disorder. And all this cartoon is here is to show you that these regions, the colored regions where these compounds are made, are actually distributed widely within brain, and again are a likely contributor to any degree of dysfunction as well as the manifestations that a patient may have. Now, this is, he had a better picture than I did, but this just gives you an idea of what we think about executive functions or management of these cognitive processes that are involved in regulation and control. I like the idea of a frontal system as opposed to frontal cortex, because these do not exist by themselves. And these regions don't work on their own. They have to connect to the rest of the brain to actually perform anything. But they do perform this, in general, inhibitory function. So can we think of Tourette syndrome as a disorder of executive function? Is that what it is? I think that's a valid way to think about this. Tics are perhaps an example of an inability to inhibit kind of normal, automatic, stereotyped behaviors. OCD anxiety. The problem here is, or at least one way to think about this, is that we all, every day, we all have thoughts that are scary, unusual. What if I fall out of, or fall down the stairs? What if I, but the elevator that I'm in drops and I die? But we typically ignore that stuff. We think about it for a second and we just ignore it. We say, that's crazy, forget it. A person with OCD, on the other hand, has trouble letting go of that thought. That thought can become very consuming. And so one way to conceptualize this is that they have a disorder of inhibition. With respect to attention, I think it's a lot easier because many of the functions that Dr. Murillo mentioned are clearly the types of things that people with an attention deficit have. Difficulty with organization, difficulty remaining on task. So again, that's a lot easier to see. But overall, one could consider many of these manifestations of Tourette syndrome as a deficit in executive function. So the last thing I have to say, I don't think Hippocrates was talking about Tourette syndrome, but it's more important to know what sort of person has a disease than to know what sort of disease a person has. And what I think, the way I interpret this is that Tourette syndrome is probably imperfectly considered, especially if you only think of it as a tic disorder. There is much more that goes on here that has to be addressed. And so that's why it's so important to get a good assessment of where the distress and impairment are coming from. More often than not, it is not from the tics. It is from these other disorders or problems, which I think I would tend to agree with can be attributed to an executive function problem. So I'll stop here and allow Jan to come on and we'll take questions later. Thank you.